All right, now we're going to enter in complications of pregnancy and labor and delivery. So it is a big document. I'm going to try to chunk it up in terms of sections. And this section will be on pregnancy bleeding. There's early and then there's late. We'll talk about early now. We'll get into the late pregnancy bleeding, and then we're going to look at some pictures. So this is a very difficult topic to cover, and it's very hard for some students to hear it because I'm sure they've had some experiences with friends and family, maybe even themselves. So to hear about complications is really fraught with a lot of emotions, and I definitely recognize that. All right, so let's take a peek here. SAB, TAB, EAB, spontaneous abortion, therapeutic abortion, elective abortion. And this is their definitions. So what we do mostly in OB, we deal with mostly spontaneous abortions. In the GYN world, they deal with therapeutic and elective abortions. So what we mean by that is a termination of pregnancy before viability, about 20 to 24 weeks. And we're always going to constantly review Unit 1. You're thinking, okay, so viability is the marker of weeks where the baby can be viable, but necessarily not survivable, is week 20, possibly as early as that, but most babies are up to 24 weeks is viability. Preterm is 20 weeks to 37 weeks and 6 days. 38 weeks to 40 is term. After 40 is post-date or post-term. So you're thinking, okay, so what would happen here is incidence, it's reportable. I think this number percentage is probably low because it's self-reportable. And we say that about maybe maternal substance abuse, not that I equate it to that, or gravidipara, of course, we talked about, and relates to number of abortions. It's basically what? Underreported or overreported? It's usually what? Underreported. So even infections, STIs, underreported. So 50% of SABs is usually due to their spontaneous. We have early SABs, which most people, lay people, call miscarriages, 80%. That's less than 12 weeks. Late SABs are between 12 and 20 weeks before the time of viability. And you can look at this and you can look at this. And we've talked about some things before, like infections and substance abuse. And you can say collectively, I can understand why things happen in terms of fetal, what we call fetal and embryonic loss. Also, in the majority of cases, they do not know why. They don't know why, and they don't know the etiology. It's even beyond these causes. So we see a lot of endocrine imbalance, not so much from diabetes, but the progesterone and estrogen, the levels. And for some reason, the levels drop and they don't know it, and then she miscarries. So let's look at the type. Now, I want you to differentiate the type. You're going to have to look at the pages in the book and the pictures, and I'll present the pictures. But draw a heavy line right here. And we're going to look at different types of abortion, spontaneous abortion. And so we're going to take a peek and say, all right, overall, before I even start this, I know you can read this yourself, but I help you differentiate it, and I try to troubleshoot to what some other typical questions students have for this content. So let's just review one thing. In Unit 1, when the mom is pregnant, remember you kind of want to write it off to the side here. Maybe you can write it here or here. But when we look at pregnancy, and we always want to compare this to normal, always understand the baseline for all this stuff. That's what we're talking about in Unit 2. If we understand normal, we can understand the variation outside of normal parameters. So when we look at this, normal is when the mom is pregnant, she should have no bleeding, no vaginal bleeding. Remember, no cramping or pain, and no discharge. Discharge is amniotic fluid. So 3 things you should never have besides the leukorrhea, which is normal. No pain, no bleeding, no discharge, which is amniotic fluid. And unfortunately, we see this those three things in different combinations here. If we draw a heavy line here, these nursing care items are not like associates with the type of right here. This is the overall collective nursing care. So we'll talk about that in a minute. Over here is threatened abortion. You're thinking, what are the difference? And just try to take the word as it is. Take it for full face value. Threatened means that it might, but it may not be happen, but it's threatening to. And all of this, students get kind of caught up in this. You do have to know it, but it usually means at the beginning. Because, you know, if she bleeds a lot later, well then, you know, it could happen. But at the beginning, she has an amount of blood slightly spotty, slight cramping, no passage of tissue, closed, and usually, remember, the fundal height agrees with pregnancy length. So we tell her to bed rest, sedation, avoid stress. Maybe she works as a waitress. She works at Home Depot. She's on her feet a lot. That means threatened. We still hear a fetal heart tone. Inevitable means inevitable. I mean, it's going to happen eventually. Rupture of membrane. Cervical dilation, product or production of conception past. So we call them product of conception, unfortunately, because that doesn't only include the baby, embryo, or fetus, but also includes the what? Placenta. So it can be moderate, mild to severe, no passage of tissue at this point in time, but it's going to happen, you understand, inevitably. Obviously, the cervical os is open and uterus size, fundal height agrees with gestational size. Incomplete, meaning part of it is retained, the placenta, and sometimes the fetus is expelled. Of course, if the placenta is retained, remember we learned in Unit 1, it's heavy and profuse bleeding because it's still attached and the uterine arteries are still open. Severe cramping, trying to get the placenta out. Yes, passage, it's the baby. Os is open and smaller because the placenta is intact. It's still inside, but the baby is gone. What do we mean by D&C? Dilation and curettage. They will put something inside her, which we can use different chemicals to dilate her, and then dilate the the cervix, and curettage means to scrape the products of conception out. These are the procedures used for when someone goes in, let's say, to Planned Parenthood, and they get therapeutic or elective abortion. Complete means all fetal tissue expelled. So slightly at the beginning, mild at the beginning, closed at the beginning, but we don't do anything. No medical management if the uterine contractions subside. However, we must hear if she hemorrhages and of course if she's infected. But if she's not hemorrhaging and she's not infected, medical management is not there. We just kind of have her call us, telehealth, and see how she's doing. Of course, emotionally it must be hard. Missed fetal death, meaning missed abortion, is the common, and these are the sad situations where the mom comes in and there's no heartbeat. We missed it somehow, we didn't know when, and we didn't know how. It's not immediate spontaneous abortion, so she's closed. And sometimes it's at the most spotting. So what we can do, it depends on the size of the baby. You can do a spontaneous evacuation if it's very, very small. If it's not, they won't do a spontaneous evacuation of the uterus. At this point in time, if the pregnancy is well in its weeks of gestation, they will terminate the pregnancy depending on mom and what she wants. So we can have the medical management. We have her come into labor and delivery, and we can give her prostaglandins or Pitocin and reduce the labor and terminate the pregnancy at that point in time. If she says she doesn't want to do that, if she says, no, I want to stay home and I want nature to take its course and I want the body to go into labor naturally, we can have her to do that. But the problem with doing that, we got to make sure, we call it retained fetus syndrome. We've heard of that. The body might, quote, quote, reject the tissue. The tissue is dying, and it might therefore clot. And it might go into a DIC. We learned that in preeclampsia. Or the mom might get septic because maybe the cervical opening is a little bit open, allowing ascending infection. So we have to really watch her for that if she decides to stay at home and not have anybody terminate the pregnancy and just waiting for nature to take its course. So she can do one or two things. She can have the medical management do that, intervene, or she can wait for termination of that pregnancy. Septic is what it means. She has sepsis, fever, abdominal tenderness, malodorous discharge. Everything varies. And what we'll do is cervical, CNS, culture and sensitivity, give her antibiotics and treatment for septic shock. That could be a problem with septic shock. We use the word recurrent or habitual loss of 3 or more pre-viable pregnancies, meaning that in the chart might say recurrent SAB, habitual SAB. And that means she's had 3 or more SABs. Everything varies here, so depending on the presentation, how many weeks. The big line here is drawn. You want to say, okay, so what would they do collectively overall for these moms? And it's all about what? It's all about fluid support. Make sure she doesn't hemorrhage. Make sure she doesn't clot, overly clot, get DIC, and then make sure she doesn't get infected. So IVs, lab, we do a biophysical profile. Remember, that's level 2 ultrasound to look at the baby and look at all his structures. Make sure she gets prenatal labs done. Make sure we get all the RH factors and CVC and all that done. Check for her rubella status. UA, rule out UTI, UACNS, chest x-ray, rule out maybe pneumonia or infection, rule out heart disease or heart issues. We talked about that in preeclampsia and the cardiac lecture. Check for chief complaint. What is she saying? What is she complaining? Always zero in on what she says when she comes in. It's a huge, huge marker for what may truly be happening. Listen to the mom. Excuse me. Vital signs, OB history, very detailed, nothing vomiting. Remember the pain, the bleeding, and make sure she's not having rupture of membrane. So pain, bleeding, and no vaginal discharge. Amniotic fluid. Check for a level of consciousness. Immediately put the EFM on her and listen to the baby. Look at the strip of the baby. Do fetal surveillance. Check for contractions. Of course, her emotional state, that's very important. I mean, it's very, very heart-wrenching, I'm sure. Pre- and post-op care, she becomes a surgical patient if specifically, let's say, she needs a D&C. Prostaglandins are given to her if we need to have her going to labor, and even Pitocin, we mentioned that. Antibiotics, if we suspect, or we can say do it prophylactically. If we suspect there might be possible infection. Remember broad spectrum, the Cillins, the cephalosporins will be probably given to her. Analgesics, of course, if she's cramping and pain. Rogam for all Rh negative moms. If at any time that she thinks she's pregnant or she obviously has a positive HCG and she's tested as Rh negative, and we have any time of an embryonic or fetal loss at any time during the pregnancy, even like 1 or 2 weeks into the pregnancy, we are going to give her what? Rogam for the Rh negative moms. We learned that in Unit 1. Psychosocial support, discharge teaching, follow-up, referral, and support groups. Okay,